my honor and pleasure to have this talk with you. And let me introduce you to the guest of this talk, John Hannan from the Netherlands, Olivier Michelin from Switzerland, Marco Donia from Denmark. Honor and pleasure to discuss with you the development of new therapeutical approaches with immunotherapy for solid tumors. And I would like to state that we will discuss in details 4 works that have been presented at this ESMO 2020. It's going to be a great pleasure to discuss the first 2 abstracts because they resemble a very similar approach to double targeting PD-1 and CTLA-4 for solid tumors. The first one has been presented by Sharma et al. And it presents the use of MGD019, a bispecific anti-PD-1, anti-CTLA-4 molecule in patients with advanced solid tumors. And the second one that has been presented by Millward about targeting PD-1 and CTLA-4 for patients with mesothelioma, which is relapsed or refractory to standard therapies. And I go directly to my first question. So what do you think about targeting at the same time 2 molecules with only 1 drug? Who would like to start?
I think that the general advantages of targeting CTLA-4 and PD-1 with a bispecific antibody is basically the possibility to target the molecules on the same or nearby cells. This can be a critical advantage if we consider that tumor-infiltrating lymphocytes often express these checkpoints at high level on the same cells. So this is one of the potential advantage. However, there can be some disadvantages. For example, the lower flexibility regarding the dose level or the timing if you are thinking about doing some specific sequencing strategies. However, there's not been any specific signal of higher toxicities compared to standard combination of CTLA-4 and PD-1, using as reference the dosage that we use in melanoma, so EP3 Nivo 1.
Olivier, what do you think about the advantage of using only 1 drug instead of 2?
I think, of course, it's convenient to have only 1 infusion to be done compared to 2. I mean, there is a practical side to this. I think, what is really important is the biologic change that you are going to induce. And I think I will really also echo what Marco is saying here. I think it's a very complex biology, and having a bispecific antibody has some very interesting properties. Again, you're going to target specifically those cells that express both. But I think there are also some threats and some open questions which are going to be very important to answer. One of them is what about the non-canonical mechanism of action? For example, CTLA-4 could deplete regulatory T cell. Is this mechanism the same on a bispecific, or is it different? So I think there is a lot of biology that needs to be understood. But I think clearly, one of the advantages is the fact that perhaps these drugs are going to be less toxic because they really need to co-engage PD-1 and CTLA-4 for their full action, and maybe the systemic toxicity might be less. So I think it's a very interesting approach.
John, do you see, John, any possible utilization of this antibody? Would you move forward? What is your feeling about that?
I think that putting both CTLA-4 and PD-1 blockade in one molecule could be advantageous. But on the other hand, when we look at the mechanism of action of CTLA-4 blockade and PD-1 blockade, and especially when listening to Jim Allison, who is really the person who developed CTLA-4 blockade, I've always had the impression that CTLA-4 blockade works at a different site than PD-1 blockade. PD-1 blockade is mostly in tumor environment, but CTLA-4 blockade is more in the tumor draining lymph nodes where immune responses need to be induced. In mice, there's clearly an effect also of CTLA-4 blockade in depletion of regulatory T cells, but that has not clearly been proven also in the human situation. Now, if you look at these two molecules, one of these molecules doesn't even have an Fc portion, so depletion of Tregs would be quite difficult for that drug to DARPin. So, does it do the same thing? Do they need to work, let's say, close in areas where T cells can be engaged that have expression of CTLA-4 or PD-1, or do they still work at different sites? But then, you don't have any advantage of the PD-1 moiety. In terms of toxicity, you could say, well, maybe you have a 1-to-1 ratio of both drugs. You infuse them. But the advantage of having two drugs is that you can leave one out when toxicity is being induced, whereas in this situation, you cannot, right? And CTLA-4 is mostly the drug that is inducing most of the toxicity, so we cannot leave that out. So I'm not 100% sure it's going to be an advantage. And I'm also not 100% sure that the mechanism of action is truly representing how these immunotherapies work.
Said that, I think that then probably the strategy of using these antibodies, for example, for mesothelioma, which is a very confined tumor, then it makes probably sense. So therefore, we know that the study presented with the 1021, it is specifically started, has been specifically studied for mesothelioma, which means that this would go in line with what you have said. So if we have a highly confined tumors, maybe this is a good strategy to adopt. But
maybe yes, yeah. But
right?
You could also, in this situation, if you look at let's say the objective response rates of Ipi/Nivo in mesothelioma, it's up to 30%. Here it was 20%. Toxicity seemed to be less, but then it was also based on very few patients, right? So it's very difficult to say how these drugs compare to two separate antibodies. But you're right. So for certain situations, it may be advantageous to give the combination. Yeah.
So, like going back to what also Marco was mentioning at the beginning, if we have to foresee how to develop these therapies further, and taking all together the messages from all of you, probably it has to do with a specific disease where probably we are targeting like a locally growing tumor. That would make one sense. But on the other side, we will have the limit of dosage in terms of, or in the presence of side effects. And it's important to state that when we look carefully at the side effects of the first study, these were pretty high, I have to say. And I think I was a bit astonished, because I was believing if this would have led to less toxicity because of just because of the double binding, right? So are you surprised by the toxicity or not at all? Marco?
So I'm not surprised by the toxicity. If I remember well, the first study, they had very toxic side effects, or the majority of the side effect with the highest dose that they used. And this was, I think, 10 milligrams per kilo. So I'm not sure how this would translate to a CTLA-4 antibody alone to 10 milligrams per kilo plus an anti-PD-1. So in general, I would not think that with the very early indications that we have do not seem to be at least more toxic, but then there's a lot of open questions.
Let's see, they have mentioned that future studies are developed. We are going to see in the future how it works. We move to the topic of chemotherapy combined with immunotherapy. And I think, of course, this is a very broad topic. In order to discuss this, we picked together this abstract, the 1026, which concerns the use of this new, let's call it new, or more modern platinum therapy together with avelumab. So you have seen that in this study, they have used this new compound, which seems to be very interesting because it might engage immune responses. what is your thought about the use of this drug? And what is your thought about, in general, what would be the best partner that you see in terms of chemotherapy with checkpoint blockade? Let's start with John.
Thank you, Sandra, for asking this question. So let's start with the pyrophosphate platinum compound, which is an interesting drug. So it works very different from platinum, right? It doesn't do the same thing as normal platinum does. It's targeting to especially bone. So it was very interesting to see results also in castration-resistant prostate cancer patients, and they combined it with avelumab, an anti-PD-L1 drug. The idea behind it is inducing immunogenic cell death, and I think it's important that there is some kind of validation that indeed immunogenic cell death is induced by these drugs also in vivo. It would be nice to see that. We know that certain chemotherapies can do that. We know that chemotherapy combined with the checkpoint inhibitors already has been shown for many of the tumor types can have additional effects, maybe sometimes even synergistic effects. So having a chemotherapy like agent that is not so toxic than chemotherapy would make an enormous step forward. So I was impressed. I was also excited about this new approach. And of course, we have to see how it will do in the clinic. But combining it with a checkpoint inhibitor in this situation makes sense.
What about the use of this platinum drug, Olivier, because they require often the use of corticosteroids? Any thoughts about the when using a combinatorial treatment, would you avoid a drug that requires steroids? We don't know yet from the presentation of the study about how much steroids was needed as together, but what is your thought, Olivier, and afterwards, please also Marco, about this when you have to use a drug that might need steroids? Any fear, no fear?
Well, I think steroids are really sort of devastating for the immune system, depending on the dose. So I think it's clearly not a good idea to try to combine with steroids. Now, it might be required, and maybe dose might be an issue where you can still have an engagement of the immune system. But clearly, I think there might be ways actually around the steroids, depending on the treatments, and maybe that's another area where great progress are needed. Is hard to be more subtle about the way we work with the sort of immunosuppression that we need for different treatment types, and maybe in the future steroids will no longer be the absolute first resort. But yeah, I think it's an issue. I think it's not the ideal situation when you have to give a steroid within immunotherapy. If it's short course, if it's lower dose, it's okay. But clearly, I think it's something to take into consideration, because that could greatly limit the benefit of IO.
Marco, what's your feeling about this new platinum compound together with immunotherapy? It's a new way through?
I think that in general, the concept of immunogenic cell death is great, because if you can induce it with chemotherapy or with radiotherapy or with other drugs, and then stimulate the immune response with checkpoint inhibitors, that could be a game changer. But as you said, there can be problems both with steroids, and also I have not seen that really the effects of this drug. What are the effects on the immune system, on the immune cells themselves, not just on cancer cells? So as I commented previously on the combination, I think that we need to consider the timing of this. Should we first induce immunogenic cell death and then start with immunotherapy, or should it be given at the same time? Now, in this study, which is of course a phase 1, and clearly the objective is to understand the feasibility and the toxicity, this was done at the same time. But perhaps future studies should clarify whether the timing is important here, as it has been shown extensively in preclinical studies, for example, by Bernard Fox, that giving PD-L1 plus OX40 can be critical it can be critical when you start the anti-PD-1. We have seen also in melanoma study, Checkmate 64, that can be critical starting anti-PD-1 before anti-CTLA-4, or the opposite. They give very different effects. So I would be careful here in concluding something by some drugs given with a relatively unflexible strategy at the same time, plus potentially steroids that can even confound the effect on the immune system. So I would encourage to make studies on the timing of these combinations.
So you would recommend that probably a development of this strategical approach could be to look at the different drugs, starting with one first and the other one afterwards, or maybe at the same time. This was actually also not only the timing, but the fact of giving the drugs together or not was also a matter of discussion of the stimuli trial presented at this conference for small cell lung cancer. If there is any effect by giving the immunotherapy after a while after chemotherapy. This is an important topic, and this absolutely requires, as you are suggesting, Marco, absolutely further research. And I assume, as you were also mentioning, not only preclinically, but directly in patients, because sometimes in the preclinical models, we don't see the exact effect as we would see in humans and in patients. And often we forget also in preclinical model the confounding role of co-medications, right, as you were mentioning. If we have to strategically say how to move on with the next partners, if it's not chemotherapy, as for this diet, and we think about other immunomodulatory molecules to combine with the often used anti-PD-1, PD-L1 drugs. What about the last study that we are going to discuss? So the 1025 using the 4-1BB and FAP targeting antibodies. I personally thought this as a very interesting approach. And of course, this has been used and tested in several solid tumors. And I have seen at this ESMO 2020 many approaches to target 4-1BB. What do you think? Is this the next fundamental partner for targeting, for immune checkpoint targeting molecules and approaches? Or what is your thought about targeting 4-1BB? Let's start with Olivier.
Well, I think it's extremely interesting developments. I think this is actually further development of agonistic 4-1BB antibodies, and I think the toxicity here was limiting. That's actually an issue with a lot of the agonistic antibodies that are targeting stimulatory checkpoint. And I think the idea of linking this to FAP is of course brilliant, because then you would really home your compound to the desired location. So I think it's very early what has been presented in that abstract, but I think the strategy is absolutely interesting, and it should be pursued. I think this type of developments could really be fueling the future of IO technologies for the years to come.
Marco, some thoughts about 4-1BB?
4-1BB is a stimulating agent, so it's conceptually different than using immune checkpoint inhibitors. But on the other hand, it's stimulating an immune response which is already unleashed. That could be, a goal strategy that can induce tumor regression. Now, as I heard, the main issue of using 4-1BB antibodies alone is hepatotoxicity. So the idea of localizing the immune response induced by 4-1BB directly in the tumor microenvironment is great. However, it can be used, this idea, not just for 4-1BB, but for any type of T-cell stimulator, or even for checkpoints. So I think that the technology itself is the real innovation here, not just using the bispecific for FAP and 4-1BB. And I would like to see this technology not just used in this context, but also in other contexts with other antibodies. I think that can be potentially a game changer.
John, What do you have the same feelings? Do you see any limits to this technology or approach?
No, I think this is just a start of a new approach of targeting immunotherapies to certain areas, and especially the tumor microenvironment. I think the concept of having let's say an anti-FAP antibody, which was already used in combination with interleukin-2, was used in combination with an anti-CD3 antibody. So that concept was already present, and you really target these drugs then to the tumor microenvironment. Now it's being combined with a immune stimulatory molecule, and you can see that there is clearly also the toxicity coming from an immunostimulatory molecule with the cytokine release syndrome in a patient. So that it is doing something, right? And hopefully it's doing it by indeed stimulating T cells within the tumor microenvironment that give them the cytokine release. But in order for these molecules to really work, you need also T cell receptor engagements, or at least you have to unleash the T cell response within the tumor microenvironment. So I think by themselves, these molecules may not be so active. You have to combine it probably with an anti-PD-1 or anti-PD-L1 drug. Now, this drug was being combined with atezolizumab, and you did see some more toxicity, which was also related to the atezo. But I think that in itself is probably an interesting combination, because you need T cells that are able to recognize the tumor, and then the effect of a 4-1BB interaction could even stimulate or enlarge the immune response. Of course, it all needs to be proven in further studies. The concept itself is great. Yeah.
Well, I think absolutely I agree with this, and when I looked at the paper first, of course, I was recalling our data on using CAR T cells targeting FAP. And of course, I was also wondering if it would be any chance or any reason to use also local treatment with such antibodies instead of systemic, in order also to reduce the possible toxicity. So do you think it would be a way probably to develop this drug for local treatment? Would it make any sense to combine it then with some systemic immune checkpoint inhibitors? Olivier?
Yeah, I think it's a great opportunity. If you think about injecting, for example, a PD-1 in a tumor, as soon as the PD-1 dissociates from the target, it's almost in infinite dilution. So it's going to go away in the body, and there is little chance to rebind, which means that the kinetic is almost driven by the molecular dissociation kinetics, which is extremely short. And so having a way to increase the binding locally to the microenvironment is of course extremely desirable, and that's a way. There are other technologies that would help retaining the monoclonal antibody longer in the tumor site injection, but I think IT therapy is certainly a place where FAP binding could play a role. Absolutely.
So one last comment, and we're going to conclude our talk from Marco and John. Where do you see from all these molecules that we have discussed now, would you like, or which one would you like to have in your department, and which one would you like to use to be tested or at your sites?
Well, in fact, I would love to use all of them, because I think they all represent very new and very innovative ways of trying to understand and find ways to improve the immune responses that we want to induce in patients with cancer. And especially some of these compounds seem to be active in tumor types where normally checkpoint inhibitors have not been so effective, like colorectal cancer, the macrocyte stable colorectal cancer. All of that would be very interesting to study. But I think that we have had some experience with the anti-FAP drugs. So I would certainly be interested also to be involved in the further development of that the drug in itself. But all the others are also something that I would really like to work with.
I would like to thank very much Olivier Michelin from Switzerland, Marco Donio from Denmark, John Hannan from the Netherlands. It has been a real pleasure to discuss this with you. And thank you very much for your kind attention. Have a great day.